Our next speaker, and I have to confess, when I looked and saw that Marshall wasn't sitting where he was just before he knew he was supposed to be called up, I thought, that's an odd time to go to the washroom. But turns out Marshall was on call, and his pager went off, and that's where he was. So I'll add to my introduction to Marshall. Marshall is the Psychiatrist-in-Chief at the Hinks-Dellcrest Center for Children and Families in Toronto, consultant in the Division of Youth Psychiatry at Sunnybrook Health Sciences Center, an associate professor in the Department of Psychiatry, and a consultant to Jewish Family and Child Service, a long and distinguished career in child and youth mental health, published broadly, public speaker, as you'll see, of excellent renown, and an outstanding advocate for mental health care and treatment for children and adolescents. Marshall, thank you so much.
Thank you, Mullen. And I do apologize, I am on call, and so I had to take a call. Mullen and I go way back. We were, in fact, in the same cohort of psychiatry together. We did our final year of residency at Mount Sinai Hospital together, and I think each of us have watched our mutual careers with mutual admiration, and so it really is a pleasure to be here. So what I'm going to talk to you about this evening is depression in adolescents and then suicide in adolescents. And the way I'm going to frame my talk is to try and answer hypothetical questions that I think you may ask. We'll see when we review the questions that have been submitted. Maybe I've anticipated some of them, maybe I haven't, but that's how I'm going to frame my talk, is the answers to certain questions to try and educate you about depression and suicide. So first of all, a common question that I get asked is, what's the difference between normal teenage moodiness and clinical depression? What's the difference between normal and abnormal, if you will, or clinical depression? Three things: persistence, severity, and pervasiveness. Persistence meaning that the depressed mood has to be there the better part of a day, almost every day, for at least 2 weeks. The 2 weeks is not picked out of a hat. That figure is based on empirical field studies that show that when a depression lasts less than 2 weeks, it's probably going to be self-limiting and resolve on its own. But when it lasts longer than 2 weeks, it tends to have a life of its own and merges into what we call clinical depression. So that's persistence. Severity. To be clinical, there should be functional impairment. That means the teenager is not able to get on with the things that he's supposed to be doing. And in teenagers, that usually manifests as a decline in academic performance, or poor peer relations, or increased conflict with family. So there's impairment in the average, everyday things that the teenager ought to be doing. And the third thing is pervasiveness. So it's one thing to be sad, and that can be pretty bad, but that doesn't make you clinically depressed. In order to merit a diagnosis of clinical depression, it's depression plus. And this is what the plus is. And by the way, in children and adolescents, you're allowed to substitute irritability for depression. So that's an important point, that when a child or adolescent is depressed, they don't always say, I'm sad. Instead, they can be prickly. I call it prickly. They're irritable, easily upset. And it's a change from their usual self. Okay? So it can be sadness or irritability that lasts at least 2 weeks, causes functional impairment, and it's depression plus. What's the plus? Loss of interest or pleasure in most daily activities. We call that anhedonia, from the Greek meaning inability to derive pleasure. Change in appetite, either up or down. So in depression, we can see too much eating or too little eating. And if you lose or gain more than 5% of your body weight in a month, you're getting into the clinical range. Change in sleep, again, either up or down. So we get insomnia or we get hypersomnia, sleeping too much, wanting to nap during the day, wanting to nap during class, and so on. Changes in motor activity, either up or down. So we get agitation and restlessness and a feeling of being hyped up for no apparent reason, or what we call psychomotor retardation, which means slowing down. One of my patients once said when they were depressed, it feels like I'm walking through peanut butter. So if you can imagine what it's like to walk through peanut butter, that's what clinical depression does to you. You feel slowed down, and every effort you make to move and to think, it's an effort. Okay. Loss of energy or fatigue, very important. And here's where I make my pitch for you as parents to please have your teenager be seen by their family doctor or pediatrician first. Because there are 3 very common medical conditions that mimic or can look like depression, but they're not. And in teenagers, the commonest ones are anemia, low thyroid, and infectious mono. Okay? If a teenager is anemic for whatever reason, or their thyroid is underactive, or they have a viral illness like mono, they can look depressed because they have fatigue. Okay? So I, as the psychiatrist, want to rule those out first, and they're all easily ruled out by a simple blood test, and most of them are easily treated. Before you come to me, let's rule out the physical before the psychological. Feelings of worthlessness or excessive guilt, so assuming responsibility for things that really they're not responsible for at all. The mood is depressed or irritable. Decreased concentration or ability to think. So that one's going to take its toll in school. So they really can't concentrate. It's not that they're lazy, it's not that they're not trying. This is a can't, not a won't. That's the difference between clinical depression and something else. It's a can't. Okay? And then the last symptom is recurrent thoughts of death or suicide. So if you have any 5 of those 9, and it lasts 2 weeks and it causes functional impairment, you're into what we call clinical depression territory. Second question, what causes depression? Well, as with most things, it's a combo of nature and nurture. On the nature side, we have genetics. Okay? Mood disorders run in families, whether it's straight depression or bipolar illness. There's definitely there's a family history to this. The more first degree, what we call close or first degree relatives you have, the greater the probability that you're going to be at risk for getting depression. That doesn't mean you're going to get depression. Genetics is not destiny, and we can come back later to that question. So, and the other thing about nature, on the nature side, is physical illness. So often, if the teenager has what we call a coexisting or comorbid physical illness, whether it's diabetes, epilepsy, cancer, that's going to make them depressed. And of course, that's understandable. On the nurture side, we have loss. So, as you heard eloquently and poignantly from Danielle, a death of a close relative, death of a pet, or anticipated death. Loss could be a breakup of a relationship. Loss is a trigger for depression. Abuse, physical abuse and sexual abuse, absolutely a risk factor for depression. Neglect, parents are too busy, tired, depressed perhaps themselves to be aware of and pay attention to the teenager. So neglect. Marital discord, high conflict divorce, kids absorb it like it's toxic in the air. Okay? If the parents are fighting and they can't contain it to themselves, the kids are going to be caught in the middle, and that can contribute to depression. What we call narcissistic injury, or a hurt to the self, and one of the commonest ways that happens, and you've heard mention of this before, is bullying. Okay. In-person bullying or online bullying. Cyberbullying is a huge risk factor for depression. Poorness of fit between the kid, who may be different by virtue of any number of things, and their family or their school or their society. A very common example of this is someone who is lesbian, gay, or bisexual, or transsexual, or transgendered. Those folks are at higher risk for being depressed, and it's usually because they're not accepted by their family or their school or society. So in general, we have so-called biological depressions and psychological depressions. Most of the time, it's a combination of the two. And study after study after study shows that when you combine antidepressants with psychotherapy, the treatment results are better than either one alone. Okay? So on the pure side, biological depression equals strong family history, genetics. The depression is presenting with physical symptoms primarily, so changes in sleep, appetite, energy level, concentration. And there's not a history of environmental trauma. There's no abuse, there's no neglect. So when it presents like that, we think, okay, this is like a this person, quote unquote, has no reason for being depressed. The family is good, there's no divorce, there's no conflict, but there's a family history, and they're presenting with disturbance of sleep, appetite, energy. That's a biological depression. Distinguished from the more psychological depression, so it's a complete opposite. Now we have no family history, so there's not genetics. The presenting picture is psychological, so they present with things like helplessness, hopelessness, worthlessness. And there is a presence of environmental trauma, abuse, neglect, bullying, that kind of thing. That's a more psychological depression. Okay? Does that make sense, what I'm saying? Right? The importance of this is, and it leads to treatment, right? If you have a more biological depression that's quote-unquote biochemically caused, we tend to recommend antidepressant medication. Whereas, if it's more psychologically caused, we tend to recommend psychotherapy. Okay? So that's how we treat depression, either medication or psychotherapy. Best outcome is with a combo of both. Why is it important to recognize depression? Because it is a treatable illness. Okay? In 70 to 80% of cases, we can get the depressive episode under control. The flip side is if it's not treated, there's an extremely high recurrence or relapse rate, and there's serious complications, the most serious being suicide. So that's why it's important to recognize depression. This is fixable, but if we don't fix it and it goes on, as Dr. Lesh said before, there's a very high likelihood it's going to recur, and of course you can get into suicide. Okay, so now I'm going to shift gears from depression and talk about suicide in adolescents. And I'm going to talk first about what are the protective factors against suicide, because I'm going to come back to that at the end as well. What are the top 10 rewards, motivators, needs of teenagers? What are the things that make them happy and healthy and feel good about themselves? These are the protective factors against suicide. Autonomy or freedom. Status. The chance to have adventure, exploration. That's what the teenage brain is all about. Feeling of immunity from strength, that feeling of invincibility, strength, which comes from competence. Social acceptance or fitting in, and I'm going to come back to that one because it's so important. Saving face, that's really important, and you'll see why in a minute. Winning, okay? Some teenagers are very competitive, so a high sense of achievement. Regulation over their emotions, control over their emotions, and control over their environment. And then the last reward, if you will, or motivator is emotional and or sexual intimacy. So the chance for a deep, meaningful relationship, feeling close to someone emotionally and physically. Those are the top 10 motivators, rewards for teenagers. Regulating one's emotion is really, really important because what we call emotional vulnerability is a high risk factor for suicide. And what I mean by emotional vulnerability is, and this is usually temperamental, high sensitivity. So there's a low threshold for emotional reaction, an immediate reaction. Okay? It takes very little to set them off. Okay? Boom, they're really reactive. And it's high reactivity, extreme reaction, so they get very highly aroused. Lower threshold, easy to set them off, and then once they're off, boom, 0 to 100. And it's 100, not 10. And then slow return to baseline, long-lasting reactions, okay? So this combination of high sensitivity, high reactivity, and slow return to baseline is very commonly seen in certain personality disorders, and it's a risk factor for suicidality. Third question, what is the relationship between mental illness and suicidality? By and large, suicide in adolescence is a consequence of psychiatric disorder. Usually, emphasis usually, suicide in adolescence does not occur as an isolated act in an otherwise healthy teen as a simple reaction to some personal crisis. In 80 to 90% of cases, it represents the final common pathway of a number of converging risk factors in the context of pre-existing, unrecognized, or untreated mental illness. Having said that, psychiatric disorder may be necessary but not sufficient for suicidal behavior. If it's necessary but not sufficient, what other context is important to teenagers? The answer is social context. Because one of the precipitants for suicide in teenagers is shame and humiliation. in addition to loss. So loss is one, the other is shame and humiliation. We've now know from brain scans, from studies of what are called functional MRIs of teenagers' brains, that teenagers' brains are particularly activated when they are shown pictures of other people's emotional expressions, when they're asked to think about friendships, when they're asked to judge whether other people's feelings have been hurt, and when they've been made to feel either socially accepted or rejected. So, they're brain areas that figure out what other people are thinking or feeling cause the brain to light up. Their brains get more aroused in the areas of the brain that are sensitive to social acceptance and rejection. And their brains light up in response to other people's emotional cues. This is the so-called empathy circuit of the brain, or you may have heard about mirror neurons. The point is, when you add them all up, it means that teenagers are sensitive to social status, which makes them more susceptible to peer pressure, and they're interested in and they worry a lot about gossip. Okay? But it's not idle, and we call it teen drama. It's real. Okay? It's based on biological developmental changes in the brain that make social acceptance exquisitely important. And this is the implication for social media. Okay? Why are they addicted to their little screens? It's because their brains are craving the social aspect. And it means they're unusually sensitive to bullying, especially cyberbullying. Huge risk factor for suicide. This social sensitivity also explains what's called the contagion factor for suicide in teens. And of all the age groups, teenagers are more prone to be influenced by other people's suicides. So, we know from studies that the rates of both suicide attempts and completed suicides go up after the media have reported on the suicide of a famous person. Think about all the rock stars and musicians and movie stars you've heard of that commit suicide. This has an influence on teenagers. And that's why we get clusters of suicide amongst teenagers. Okay? So imitation is an important factor. And knowing a schoolmate who killed themselves is an independent risk factor for suicidal behavior. Again, it's this social connection, so important. If the teenager knows of somebody who committed suicide, they themselves are at higher risk for attempting suicide. So, what creates the probability of suicide, and as parents, what are some red flags to look for in recognizing suicidality? A man called Levi et al. Called suicide the impossible situation. And what he meant by that, it was a combination of severe mental pain plus communication difficulty. The impossible situation. You have this pain, but you can't, for whatever reason, and stigma is a big one, you can't talk about it. So, another person, a psychiatrist, Thomas Joyner, who has a so-called interpersonal theory of suicide, talked about these being the key factors being behind suicidality. One is a decreased sense of belonging or decreased sense of affiliation, not belonging to either family or friends. Secondly, feeling as if they are a burden to others. Okay? That's a really, really worrisome sign. If a teenager says, I'm feeling like I'm a burden to you, you need to worry. And thirdly, they have the increased capacity to act, and that usually means that a method of suicide is close at hand, that it's available. So, decreased belonging, meaning being excluded from your friends or family, feeling like you're a burden, and having the means at hand, that's a recipe for suicide. Red flags for parents, how might this express itself or manifest? Giving away stuff, giving away prized possessions, red flag, worry a lot. Talking about feeling trapped, okay, that they have no options, they feel they're just trapped. Okay? That's a red flag. If they drop out of all their hobbies and stop doing fun things that they used to do before, that's a worry sign. Okay? So those are some of the red flags for suicidality. Giving things away, talking about feeling trapped, and dropping out of hobbies. So this communication difficulty, what blocks it? What stops it? Well, it's what we're all here about tonight, and that is stigma. Stigma is a really destructive force, as Dr. Lesh said. Here's what some kids have said to me over the years as to why they don't want to talk to either their parents or to me. And it's all stigma. Talking about it makes it more real. Nothing can be done anyway. This is to the parents. My depression is so terrible that it could hurt or burden you, so I'm going to kill myself to protect you from my depression. This is how distorted the mind works, but that's how it goes. Or, my depression is so terrible that I know I'm going to disappoint you, so I will kill myself to protect me. Okay? And I won't talk about anything to anybody. I should be able to handle this on my own. I should be able to fix this on my own. How often have we heard that? Particularly men and boys, and often that's based on modeling from the fathers. If I go to see you, now it's to me, for therapy, it means my parents were right. I'm the flawed one, I'm the bad one, so why would I want to talk to you? It means my parents win. And remember earlier I said that teenagers like to win. Okay? So these are some of the things that teenagers say to me or say to their parents as to why they won't share. Okay? And it's all related to stigma. Bottom line is, mental illness too often equals weakness, and the last thing that teenagers want to be thought of is weak. So mental illness as weakness equals shame. Or mental illness equals difference and weirdness. And the last thing a teenager wants to be is different or weird, different from his peers, and again, that leads to shame and shutting down of communication. So what can we do to prevent suicide? If you're a professional, we talk about screen questions, but as parents, this is also useful for you. The number one predictor of future behavior is past behavior. So the number one thing to screen for is any prior suicide attempts. Once somebody has made one suicide attempt, the likelihood of making a second suicide attempt is increased astronomically, and more so with each subsequent suicide attempt. But let's say they haven't made an attempt before. Another really strong predictor is male gender. That's because the boys tend to choose more lethal means of killing themselves. Boys think of choosing guns or jumping or hanging. So the ratio of completed suicide is 3-to-1, male to female, whereas the ratio of suicide attempts is the reverse. 3 times as many girls try to kill themselves, but they don't complete because their method is usually less lethal, and that's overdose by pills. And you can be saved from an overdose. So prior attempt. If there was no prior attempt, gender, current or recent suicidal ideation, okay, that's what you screen for. Current depression, that's a huge risk factor, as I said. Substance abuse. Have any of your friends ever killed themselves? Okay, because again, I said that knowing somebody who killed themselves is a risk factor for contagion. And the last question I would ask is, are you being bullied? Either in person or online. Okay? If you ask those 4 questions, suicide ideation, are you currently depressed? Have any of your friends ever killed themselves? Are you being bullied? You're covering the bases in terms of what to be watching for to screen out for suicide. So we need to find and treat psychiatric disorder. We need to boost the stress tolerance of our teenagers. We need to have adequate crisis services like Kids Help Phone Line for those who are suicidal. We need to guide our media in terms of how to report on suicides because of the imitation or contagion effect. And we need to do a lot to control access to methods. Okay? Fortunately, we're not in as bad shape as the States, where guns are the primary method. So we have better gun control here. But this really does make a difference. Okay? When you limit the access to the means of committing suicide, it makes a huge difference. Okay? For example, in England, they compared areas, provinces but smaller, areas that had natural gas into the kitchen ovens versus areas where the natural gas had been banned. And as soon as the natural gas was banned, the suicide rate plummeted. That's because a lot of people use the natural gas from their oven to kill themselves. So this was a public health initiative. In Toronto, similarly, you may notice that on the Bloor Viaduct, now there's a protective wire mesh netting. That's to prevent people from jumping. When the net was put in place, suicide rate plummeted. Okay. So the last area I want to cover then is how do we build immunity? How do we Restore resilience. Dr. Lesh talked about resilience before. So these are some of the factors that go into building resilience. Temperament, okay, some of that is genetic and inherited, so we know that good intelligence, being sociable, having good drive and persistence is protective. So is having good frustration tolerance and delay of gratification. Those things can be learned. That's not just temperament. Okay? Just because you're feeling depressed doesn't mean you have to act on it. That's delay of gratification. Just because you're feeling sad doesn't mean the totality of yourself is sad. Okay? So that can be learned. Providing our kids with a secure attachment, both to parents and extra-familial folks, teachers, coaches, rabbis, extended family. We need to provide our kids with a combination of conditional and unconditional love that leads to secure attachment. Peer supports, a strong peer network. This is where the schools come in. Okay? Increased tolerance of diversity, increased tolerance of difference. Physical activity, really important. Okay? We know it works in the short term. It actually works in the long term, not just the endorphins, but it may actually have an anti-inflammatory effect. So physical activity is really important. Having the ability to regulate one's emotion and observe oneself. This comes through things like mindfulness. Okay? And the last thing is, of course, meaning, giving meaning to life, having purpose, or what one therapy, dialectical behavior therapy, calls creating a life worth living. This is a protective factor against suicide. How do we do that? Spirituality. Very interesting in studies of religion. The more religious the person, the less likely they are to commit suicide. And I'll leave the rabbis perhaps to explain what the mediating variables behind that are. But religion is actually a protective factor. Creating something bigger than oneself and knowing that there is more to the world than oneself. So volunteering, helping out, okay? Having hobbies that take you outside of yourself. These are all things that create meaning, purpose, a life worth living. So this is how we protect against suicide and we create resilience. I'm going to close with asking the rabbi, can you do it? Yeah. Okay. So there's a song. Okay, 2 minutes. It's 2 minutes. That's all. There's a song from the movie Fame that I regard as being the anthem of adolescence. It's called Out Here on My Own. If any of you have seen the movie Fame. And so this is how I want to end, because I think it poignantly describes the struggle of adolescence. If we can cue it up.
Here, we'll see if we can get it.
Okay.
Sometimes I wonder where I've been, who I am, do I fit in? Make believing is hard alone, out here on my own. Shine me home out here on my own. When I'm down and feeling blue, I close my eyes so I can be with you. Oh baby, be strong for me. Baby, belong to me. Help me through, help me need you until the morning sun appears, making light of all my fears. I dry the tears I've never shown. Sometimes I wonder where I've been, who I am, do I fit in? I may not win, but I can't be through.
So that's the song. Thank you.